Patients to begin this webinar today on COVID-19 global best practices, lessons for and from India. This is a series that we are jointly conducting with CAS. And over to you, Mr. Bhasin.
Thank you, Nisha. Thank you very much. And a very warm welcome and thanks on behalf of ICRIER and CAS, and especially to CAS, to all our distinguished speakers and participants in this seminar of tracking COVID-19 and public health, social, economic surveillance. This is the first webinar on global best practices and lessons for and from India. And I guess it could not be more relevant at this point in time. We're going through the most unprecedented event that we will probably have in our lifetimes. Certainly in India, we're in the midst of it in a way that we could have never imagined. And even 4 weeks ago, I think our mood and our tone and our thoughts around the pandemic would have been entirely different. And despite the monumental efforts from around the world, there are huge lessons that we must and will potentially, I hope, learn from the global experiences and strategies in dealing with the shared threat and rebuilding efforts, because sadly, we don't really know that this won't come back. This was our primary motivation to have this series, and it cannot come at a more unfortunate, but equally more timely time. The discussions are significant not only from the perspective of COVID-19 surveillance in the immediate term, but also the future growth and development of our country. We really appreciate your participation here, not only to enrich the work that ICRIER has been doing, but hopefully to attract the attention of all relevant policy makers in the country. In fact, apart from dealing with the immediate pandemic, which is the most dire need in this country that we have seen in a very long time, I hope we will all spend sufficient time in this aftermath to reflect and recognize all the changes that we urgently need to make in a whole bunch of areas which will allow us to weather this better and to become better ourselves. COVID-19 is defining the global health crisis of our times. You're already aware of this, so I won't go on about it. And you know far more about it with data and information than perhaps I have. Our current demographics are leading to a wave which is immense and very destructive. We did not imagine this, and perhaps certainly from my perspective, and I've said this publicly earlier, we certainly announced victory far too early, all of us, including myself. Excuse me, need some water. My apologies. The number of infections, the number of deaths, the lack of infrastructure, the lack of capabilities, the lack of forecasting and ability to forecast, as well as data collection at a time like this, when it would be so important, are very obvious and glaring issues that we must learn to tackle. Vaccines, and a lot has been done, but it's hitting the younger groups much more now than it was earlier. And we still have a long ways to go, both in India in terms of the vaccination programs, as well as in the rest of the world. Most countries, apart from a few exceptions, are in a situation where they still have a significant amount of work ahead of them. Perhaps the panelists will touch on this, but what to me has always been very perplexing is the fact that for the last 15 months, 16 months perhaps, we have all known that we will need at least 10 billion vaccines available for our entire world. And yet the astonishing part is no single country or collection of countries has put this capacity together. This is clearly a failure across for many countries, and I hope we can all think progressively about what kind of cooperation we need across the world to achieve these objectives at a time of crisis. The world is helping us at this point in time. Everybody is reaching out, and there's an enormous amount of help reaching us. And I hope in the next week or so, we can certainly feel that the situation on the ground has improved. But I hope we have many lessons to learn, many best practices to seek out, many solutions to form that will allow us to build a better world, not just for us, but for many countries across the world, because this is really a global issue. And I wonder if we truly still recognize how deep that is. Distinguished speakers of the webinar will discuss these issues in detail, so I will stop here and invite Mr. Peter Rimmele, the resident representative of CAS in India, to share his thoughts and set the stage for the thematic sessions to follow. But before that, let me share a few words about Mr. Rimmele's background. He has a first law degree from the Ministry of Justice in the German province of Baden, as well as an MA in geography. And after working as a jurist, a judge, and a lecturer, he took public office as a ministerial at the State Ministry of Interior in Saxony, Germany, between 1991 and 2000. And in behalf of the German Foreign Ministry, he served in East Timor as Registrar General, Head of Civil Registry and Notary Service, and later become the Principal Advisor for Government Reform, a GIZ, to the Ministry of Administrative Reforms and the Anti-Corruption Commission of the Republic of Indonesia, where he served for 7 years. He then moved to Rwanda as Principal Advisor, Good Governance and Justice Program. Mr. Rimmele, we have a lot of work for you here in India also in all these directions. So please, I hope you will help us in many, many different ways, apart from as the CAS resident representative. He was earlier that representative in Lebanon and Director of Rule of Law Program in the Middle East and North Africa. Thank you for being here. Thank you to our panelists. This is a critical and important topic. I hope we have a truly robust discussion. And now, if I may invite Mr. Rimmele to kindly deliver his introductory remarks. Thank you very much.
Thank you very much, dear Mr. Bhasin, dear panelists, ladies and gentlemen, good evening and a very warm welcome and thanks on behalf of CAS and ICRIER to all the distinguished speakers and participants of the ICRIER-KAS webinar, Tracking COVID-19, Public Health and Socioeconomic Surveillance. Well, every day we get the frightening statistics, but the whole lessons learned coming up is not only about statistics. We have them, but behind those statistics, there are destinies, there are people, there are life, and that is something we should not forget. Mr. Bhasin, again, thank you for your kind introduction. As Mr. Bhasin said, this is the first webinar in the ICRIER-KAS webinar series on COVID-19, Global Best Practices, Lessons for, and of course also from India. We are pleased to partner ICRIER for this very important webinar series and look forward to our continued partnership, a partnership that dates back to 2007, when Dr. Rajiv Kumar, the current chairman of NITI Aayog, was heading ICRIER, and wherein numerous joint activities have been taken place ever since. In just a few months, we have seen how the coronavirus has changed our lives and how much suffering it has caused around the world. Our health systems, healthcare workers, as well as social service providers have been stretched to their limit, if not beyond, and economies the world over are feeling the shock of this unprecedented crisis. They might continue to do so for many years to come. The COVID-19 crisis is an unprecedented wake-up call that is showing us how crucial it is for countries to have policy and legislation ensuring pandemic preparedness and prevention. COVID-19 has highlighted the critical pandemic underpreparedness of health systems worldwide. With 32.3% of the world GDP and 14.3% of its population, it is shocking to see Europe and North America account for 61% of its COVID-19 deaths. SARS-CoV-2 is the third human coronavirus of animal origin to have caused an outbreak of epidemic, even pandemic proportions within the first 2 decades of the 21st century. Back in 2003, the first coronavirus, we know it under the name SARS, the first pandemic took its heaviest toll on wealthy urban areas, spreading most efficiently in sophisticated hospital settings, shattering the myth that the exotic pathogens that cause so much misery in Africa and densely populated parts of Southeast Asia would never become a problem in wealthy countries with their high standards of living and well-developed health systems. Therefore, we are having this webinar to discuss surveillance strategies of different countries and lessons not only for, but also from India for other countries, yes, for the world. However, this pandemic also brought forth shining examples, such as South Korea, of how to effectively contain the spread of the virus without entirely restricting the regular social life of its citizens. After South Korea struggled massively to respond adequately to the MERS outbreak in 2015, the country's policymakers learned their lessons, and the government has since implemented a whopping 48 reforms to improve preparedness and responsiveness to public health emergency. I can only express my hope here that India, that the world will also learn the lessons imposed by this pandemic now. Many governments, as we know, have not done the necessary reforms. That's why these tragic proportions have been achieved in many countries. I'm not speaking of a specific one, I'm addressing many of them. And we only can hope that maybe also with the input we can deliver from this series, governments can take appropriate actions to prepare for another upcoming pandemic or similar crisis. Coming back to South Korea, overall, it has proven to be highly effective in the 3 main phases of epidemic preparedness and control, namely detection, containment, and the treatment at the end. Countries like South Korea, New Zealand, or Australia have demonstrated how we can learn from past mistakes and deploy an effective, prompt, and long-term solution to any health crisis that may arise in the future. It also proved wrong. A famous compatriot of mine, Hegel, who famously stated that the only thing we learn from history is that we learn nothing from history. Now, here we have the proof he was wrong. As far as my country is concerned, the German presidency of the G20 2017 raised health as a core concern of the G20 by convening the first meeting of G20 health ministers, who echoed Germany's focus on preventing and mitigating the devastating impact of health emergencies. They reiterated their commitments to reporting obligations under international health regulations in 2005 for potential or declared public health emergencies of international concern. Maybe you have seen somewhere the abbreviation PHEIC, as well as strengthening health system towards the same. Now, the health ministers even undertook a simulation exercise during their meeting in close cooperation with WHO and the World Bank, because such exercises provide a unique opportunity for testing capabilities, policies, and agreements, preparing and strengthening a coordinated global response to PHEIC. However, it is ironic that the top 9 countries with the highest number of COVID-19 deaths are G20 members, while Spain, a 10th slot, is a permanent guest of the G20, not to forget the continuing saga of shoddy vaccination deliveries in Europe. This is a time for introspection, to discuss and understand where did we go wrong and how, so that we can build back better for the future, and hence the need for this joint project with ICRIER. From my side, I may have 3 recommendations for G20 and maybe other world leaders. Number 1, the surveillance capacities for COVID-19 in particular, health and pandemics in general, need to be strengthened on a priority basis for robust evidence and evidence-based policymaking and interventions, especially in low and middle-income countries. Here I firmly agree with India's proposed 9-point WHO reform plan regarding the request for an international framework for the procurement of vaccines, which is urgently needed to provide a better and a more equitable access to vaccines, especially for LMICs. But even if that 9-point plan is not adapted, in my point of view, it's important that WHO takes over a more active role, because it's a world pandemic and it's the only world organization dealing with health issues. COVID-19 vaccines constitute a universal good, and without all the government of our Gaia being able to vaccinate vast numbers of their respective citizens, the pandemic will continue to haunt us all around the globe. It will not be limited to one country. Ladies and gentlemen, that would be my second point. We need to come together as a global community and work via various fora of international cooperation. To begin with, there should be sharing of global best practices. That's what we're working on for tracking and tackling COVID-19. In this context, India's 9-point plan, I mentioned it before, for the reforms within the WHO, brings forward crucial points that are urgently needed towards achieving our common goal of enhanced global cooperation in the arduous fight against the virus. In particular, the call for more transparency in data reporting, as well as access to data and disbursement of funds, are key points that ought to be implemented to allow for more solidarity, cooperation, and synergy amongst all WHO member countries. Today's webinar will provide us with the opportunity to discuss these ideas. And finally, in the spirit of freedom, justice, and solidarity, which are the basic principles underlying the work of our Konrad-Adenauer-Stiftung, we need to work out ways to continue the incremental progress on universal health coverage in the LMICs, especially in view of the disruptions caused by COVID-19 pandemic to health, socioeconomic systems, and to livelihoods. Without further delay, I would now request Dr. Nisha Tanesha to chair the thematic session. Thank you very much.
You're on mute, I think, Nisha. Oh, we can't hear you.
Just unmuting. Sorry, my apologies. Thank you, Mr. Rimmele, for your very insightful comments. In a sense, Mr. Bhasin and Mr. Rimmele have both set the stage for presentations and discussions in this session through their remarks. And so I am straight away going to invite the distinguished speakers of this session to share their views with all of us. And towards the end, in the policy brief that we will develop based on the discussions in this webinar today, we would be glad to draw a few lessons for as well as from India towards the public health and socioeconomic surveillance of COVID-19. Now, for the moment, I would like to invite Dr. Roli Mathur to kickstart the thematic session with her special remarks. But before that, may I introduce Dr. Mathur to our participants. Dr. Mathur heads the ICMR Bioethics unit and was involved in developing the national ethics policy. She is the member secretary of Central Ethics Committee on the Health Research. She's a nominee representing India at WHO UNESCO Global Summit of National Ethics Committees, and in several institutions in India. She is on the steering and advisory committees. Since 2015, she is a special invitee to the WHO CRO Advisory Committee on Health Research for Ethics and since 2017, a member of the Executive Committee of the Council of International Organizations of Medical Sciences in Geneva, and of the working group also to develop guidelines for clinical research in resource-limited countries. More recently, she has joined the WHO Expert Committee on Ethics and Governance of Artificial Intelligence in Health. So with that introduction, I'm sure our participants are waiting eagerly to hear from you, Dr. Mathur. Please, the floor is yours.
Thank you very much, Nisha, for this introduction, and I thank all the panelists who are here. I'd be very happy to talk about some of the ICMR initiatives and some of the work that we are doing in the area of ethics. So thank you very much for this platform. So as we all know that in India and in many other developing nations, there are overwhelming challenges, as we have heard our introduction speakers to say about undertaking public health surveillance, and often the initiatives in research are actually the first stage to facilitate setting up of systems for identifying public health priorities, setting up goals, agendas, looking at the ways of measurement for setting up our national policies and guidelines and programs. Surveillance, which involves timely and systematic collection, analysis, dissemination of data for suitable public health action, is so important, and it involves the efforts related to building channels of right communications, sharing of data, knowledge, resources, samples, etc. ICMR has, during the last year until now, after the pandemic struck us, stepped up to take up a phenomenal role in tackling the pandemic at the national level. It has instituted a multi-pronged approach to understand the disease and to tackle it through some of its work in the area of clinical management, diagnostics, epidemiology, building task forces, consortiums, getting into collaborations with multiple stakeholders to plan and undertake these various initiatives related to tackling the pandemic. ICMR has led major research initiatives in a time-bound manner to the emergent situation to respond to the needs of the country, whether it was in building capacity, building up a network of virus diagnostic laboratories, both in public as well as in private sector, and then developing and validating test kits, undertaking several national sero survey studies, supporting various genome sequencing consortium studies, undertaking research on environmental associations, animal to human transmission studies on socioeconomic aspects, mental health, socioeconomic well-being, and many more such studies. It has worked tirelessly towards also setting up a national COVID-19 clinical registry to collect good quality real-time data on various clinical, epidemiological, and outcome aspects of the disease. It has also developed a number of guideline documents, such as those related to treatment and management of COVID guidelines, safety protocols, clinical guidance for management of adult patients, guidance for appropriately recording of COVID-19 related deaths, and so on. Recent initiative has been in setting up a National Institute on One Health at Nagpur, which would cater to the need of systematic studies for outbreak investigations and tackling biosafety, biosecurity aspects while enhancing the diagnostic capabilities of the country. For these various initiatives, ICMR has been engaging with various multiple stakeholders and collaborating not only with government agencies, volunteers, various think tanks, engaging with public policy experts on various facets of this battle against the virus. Several symposiums have been also held by ICMR to support these initiatives. And that brings me to share with you one of the other important aspects, and that is closer to my heart, and that is our work which is involving human beings, their data set or their samples or their biological material, and that is ethics. Now, on one hand, as we all know, there is a need to undertake research quickly on a priority basis and to ensure that this does not compromise the scientific validity and the ethical requirements. Close attention is needed on perceptions of ethical questions, altered or increased vulnerabilities, healthcare provider patient, and versus the researcher participant relationships, issues related to integrity of studies, ethical review processes, and the complex issues that have been raised to tackle them effectively and efficiently. And this is the time to respond to humanitarian emergency by adopting novel methodology, designing innovative methods, appropriately using the digital platform, new technology for effectively managing the limitations of time, infrastructure, resources, and enabling quick communication. And in that, ICMR Bioethics Unit has been able to play a very important role in setting up a robust ethical framework to support COVID-related research during the challenging times. As one of the WHO collaborating centers for strengthening ethics in biomedical health research, it has responded very early on, and the national guidelines for ethics committees reviewing COVID-19 research was released as early as in April 2020, and therefore India became one of the very first countries in the world to develop such a guideline document. This document provided updated information on organizing online meetings, exploring possibilities of electronic informed consent processes, facilitated expedited ethics committees and ethics committee reviews so that research can go hand in hand and public and participants and their rights can be protected. ICMR Bioethics Unit also developed standard operating procedures for fast-track review of research by ethics committees, as time is of essence and research needs are really enormous at this point of time. ICMR guidelines, the national guidelines of 2017, already had a separate chapter, a section on dealing with humanitarian emergencies and disasters. And this is often very, gray, difficult topic. But there was also another section on public health research, which clarified the differences between, investigating as a surveillance study or versus a research or a public health program, because the distinction between these is often very blurred. On one hand, there are rights of participants that have to be upheld, and on the other hand, the right balance is to be maintained to support science. I urge the participants to go through Section 8 of the national guidelines that discusses the boundaries between public health practice and research and discusses ways of ethically handling methods for data collection through surveillance, vital statistics, disease reporting, registry programs, preventive intervention, monitoring, program evaluations, disease notification, quarantine issues, and other such challenges. It has provided some more clarity. Lastly, the ICMR Central Ethics Committee has played a very important role as serving as a national ethics committee for ICMR in reviewing research. The committee had experts from all variety of fields, and they guided ICMR-led research, whether it was clinical studies or clinical trials or epidemiological research or studies involving plasma and others, serosurveys and other investigations. The socio-cultural ethos in India and its varying standards of healthcare pose unique challenges in the application of universal ethical principles to biomedical and health research. And the guidelines have a whole section on research on emergency and disaster management, and have tackled issues of informed consent using data sets, biobanking, etc., dealing with people who are most vulnerable or have additional vulnerabilities due to the pandemic, and so that they are duly protected at all stages. And with this, I would once again like to thank you for this opportunity and happy to be part of this webinar. Thank you very much.
Thank you so much, Dr. Mathur. It was very interesting to hear about ICMR's initiatives and also about the ethical aspects in biomedical health research. Your comments were truly very insightful. Thank you so much. May I now invite Dr. Shivani Patel to make her presentation, and Dr. Patel is an assistant professor of global health and epidemiology at the highly prestigious Emory University's Rollins School of Public Health in the US. She's also a member of Emory's Global Diabetes Research Center. She holds an adjunct appointment at the Public Health Foundation of India. And she's also affiliated with the New Delhi-based Center for Control of Chronic Conditions. She recently led the development of the COVID-19 Health Equity Dashboard in the US, which seeks to fill gaps in country-level data about the novel coronavirus and the underlying social determinants of health. This dashboard reports deaths by race and ethnicity groups in the US, which is very, very detailed. And given our own diversity and the disadvantaged sections in society, we would definitely consider a similar dashboard in India as well. Over to you, Dr. Patel. We look forward to hearing you.
Thank you so much for that introduction. I am going to use slides, so may I go ahead and share my screen?
Sure, sure.
Thank you so much for this opportunity to present this work. As has already been noted, it's an absolutely critical time in pandemic response globally. I guess there's never been a not critical time in this pandemic response, but as has been mentioned, we don't seem to learn from history. So let's hope that what is happening in India currently is a lesson for our leadership and also for individuals to take responsibility in the ways that they can. And also let us hope that the death and suffering that we've seen may also be a lesson to others in low and middle income countries about how we can address this pandemic and get ahead of this pandemic when possible. Mr. Rimmele made a very interesting point that these aren't just statistics, that these are destinies that we're talking about. And I wanted to begin with this quote from a popular paper written by social epidemiologists called Bodies Count and Body Counts. And just want to cite as epidemiologists, it's a central proposition that bodies count in epidemiology. The statement would appear to be a core proposition, for it is by counting people that we derive our estimates of population rates, risks of mortality, and risks of morbidity. But bodies count for more than this. They provide vivid evidence of how we literally embody the world in which we live, thereby producing population patterns of health, disease, disability, and death. And I think connecting this, this tragic body count with the human suffering, the human experience, and also that collective experience is going to be extremely crucial as this is sort of historically, sociologically examined, as well as for the public health record and how we move forward from this tragedy. I'm, of course, speaking from the United States. So the US body count as of the beginning of this month was 30.5 million cases, over 500,000 deaths. And if we compare the US body count to the globe, Americans account for just 1 in 25 persons on this planet, yet we account for 1 in 5 COVID-19 deaths. And again, as has already been mentioned here, that it's the G20 countries that have been disproportionately impacted. And this creates some, interesting conversations and around what is happening globally. But then I think we also need to examine within each one of these countries who exactly is being impacted. And to understand who is being impacted, we have to talk about our surveillance systems. And when I was asked to provide some remarks on examples and lessons from the United States, my initial response was, I'm not sure that the United States can really provide an exemplary system, but I do think that some of our shortcomings can provide lessons. So I think that it all begins with a fragmented surveillance system and also fragmented dissemination system that has stymied many of our pandemic response efforts. So in the United States, the way that we identify COVID-19 cases and deaths begins at the ground level. So it's private and public testing sites and clinicians that must report to their local health department. That's usually a county health department. And from that county level data, the counties then report to the states then report to the national system, and this is where the national CDC begins to aggregate the data. For much of the pandemic, there were problems in the United States with respect to central leadership and transparency in the data. And therefore, I think we saw a lot of trust being placed in universities and media outlets and other private groups. Of course, the Johns Hopkins dashboard is well known to all of us, as well as many media sites. So I'm sure some of you are aware of the New York Times or the Bloomberg tracking, Financial Times, etc. And in fact, a reporter recently asked me from the Miami Herald, he said, I just want to know, why is it that I, as a journalist, am the one digging up these data? What are you all doing in public health? And I found that to be a very potent, powerful question. And in fact, I've been posing that same question to myself, my students, and my colleagues, that what are we doing here? What are we doing wrong here that the media is able to beat us to a lot of these data? There's some problem in the way that we're trained, the way that we're set up. That this is happening. Though again, I thank them for their service. The other thing that we have to think about is that trust in institutions. So one of the lessons that we've learned along the way is while as academics sitting at a private university, we are very interested in supporting the government, partnering with the government, and especially CDC, which has historically been a very well-reputed national authority and institution, the public quickly lost trust in the CDC. So we began getting queries saying, you know what, we want to know what you think as an Emory researcher. We want to know what Emory as an institution has to say on this, because we don't trust the government anymore. So that lack of trust and credibility is also quite hobbling. And I think that those of us in public health need to do whatever we can to maintain that credibility. And some of that is also, I think, maintaining some humility and not always to very cautiously publicly call out our colleagues and public officials, because that might in fact undercut our own objectives at times when we sort of erode that trust so publicly. So we have this fragmented surveillance and dissemination system, and I want to give you an example of what this looks like in the state of Georgia, where I reside. So capturing cases, these positive test results are reported through multiple sources. So there's an electronic lab reporting. So larger hospitals, larger clinics will be connected to this electronic laboratory system, but not all hospitals, not all clinics, and certainly not the smaller testing sites. So in the United States, we have these pop-up testing sites that have emerged, and many private players that are smaller. So let's say testing sites that have emerged in churches. Those kinds of sites will not be connected to this electronic laboratory system. So they might be faxing the case reports. They might be calling the DPH because a positive test report is notifiable. There's also then a separate, this electronic laboratory system I just mentioned is centrally connected, whereas in Georgia, there's also a state electronic notifiable disease surveillance system, the SEND system. So you can see already there's several streams of data just to get the cases. And this is again in the United States, the richest, most technologically advanced country in the world. When we look at hospitalizations for the state of Georgia, we only are able at a state level to capture hospitalizations that were ascertained at the time of contact tracing and case report. So that means that if the Department of Public Health learns of a case on, learns of a case today, completes the contact tracing process by the end of the week, but that case is then hospitalized next week, that hospitalization will not make it into our DPH, Department of Public Health system. So you can see how that's a problem. There are other parallel systems that the nation has stood up at the central level to directly acquire information from certain hospitals that are electronically connected. However, at the state level, this is what we're dealing with. When it comes to confirmed deaths, this is one of the numbers that we can be most confident about, and that's because these are deaths that are either reported by healthcare providers, medical examiners, and also there's a Department of Public Health team that will survey the death statistics and identify anybody in the COVID-19 case database that may have died. So we have a little bit more confidence in our ascertainment of deaths than hospitalizations or cases at large. Another big problem gap in our system is the demographic angle. So in the United States, race and ethnicity are the primary social stratification variables that we examine to understand health equity and health disparities. Race data are missing for a substantial fraction of cases. It depends on the time of data collection. So they were missing for up to 50% of the cases at certain points in the pandemic. This is due to a combination of non-response. The private labs especially prefer not to collect this information because it's a sensitive data point for many. I want to mention though that age and sex data are near complete. We're missing maybe 5% or less for age and sex. That shows us that it's possible to collect demographic data on cases. It's just that this information on race, for whatever reason, for many reasons, has become more sensitive and is more difficult to capture. And then when it comes to the dates, the date of report generation in the DPH system, the date of testing, the date of symptom onset, and the date of confirmation of, say, a death or date of confirmation of a case are all potential dates that we can use within the Department of Public Health database. Most of the statistics are reported using the date of report generation, but as those of you on the call can imagine, the date of report generation has very little to do with when that case actually arose in the population. So it provides some limited epidemiologic information. But this is the lay of the land. As you can imagine, date of symptom onset becomes very difficult when, or becomes a sort of an impossible metric to use for all cases when you have asymptomatic cases. Date of confirmation is problematic when there's a long delay between date of testing and date of confirmation, et cetera, et cetera. So then the Department of Public Health has opted for this consistency. Now, even when it comes to the case criteria and the case classification, I won't spend too much time on this, but just to say that we in the United States treat laboratory confirmed cases through a PCR test as confirmed cases. Presumed laboratory evidence is a antigen positive case, and supportive laboratory evidence is a detection of an antibody in serum, plasma, or whole blood. Now, when we go to case classification, probable cases and confirmed cases are counted at the federal level. Again, state by state, states might choose a different approach. So you might have a disconnect between what data is being reported centrally and what's being reported and recorded at a state level. These are the definitions that were put forth as an interim advisory by the Council of State and Territorial Epidemiologists on August 5th of 2020. And there's a lot of interest in revising some of these criteria because we're moving to a testing landscape where the positive antigen test, or rather the antigen test, is now overtaking our PCR tests in terms of how we're rolling out testing in this country. So given these different, disparate, and fragmented data collection acquisition approaches. At the national level, we have several data limitations. One thing, of course, is undertesting, and India knows this well. The undertesting leads to undercounting, and also the denominator for testing is always unclear for us in the United States for several reasons. And that's because a lot of testing happens outside of the electronic laboratory system, and then we don't know the denominator for the negative test. Some of these are system level barriers where there is a lack of testing availability. At this point, testing availability exceeds testing demand in the United States. It's been at different, that ratio has been different at different stages of the pandemic. But there are also individual level barriers, testing hesitancy, if you will, because people do not want to have to miss work, the fear of having to isolate and that sort of thing. There are also incomplete case investigations by health departments. Now, these are health departments, much like many other places in the world, the health departments have been chronically underfunded. They have been tasked with the monumental burden of tracking, literally thousands of cases. And I've already mentioned the issue of missing demographics. The other problem is missing data on health conditions and, for example, underlying comorbidities and that sort of thing. So as was mentioned earlier, I believe it was Dr. Mathur mentioned this, that it's important to understand these sort of epidemiologic characteristics to understand who is getting sick in the population. And again, how is that changing at different stages of the epidemic so we can better mount a response. But we just don't have these data, at least in the public health surveillance systems. We don't capture the asymptomatic cases. And then there are time lags, and I'm saying that the public mind wanders, right? So there's oftentimes in the local media, there will be like, well, the cases are rising, but the deaths aren't rising, so I guess we're in the clear. There is that sort of a notion, but of course we know that the deaths take some time to catch up to the cases. And just some of these are lags that are due to the natural history of this disease. Some of these lags are reporting lags. Now, in terms of a potential trusted metric, excess deaths is something that is, of course, on everyone's radar, because excess deaths measures deaths beyond usual mortality experiences in a population, and therefore doesn't require having knowledge of whether or not somebody died of COVID-19 or ever suffered from COVID-19. So that's a huge advantage. It can also capture the indirect mortality effects of COVID-19 through disruptions to healthcare and the economy. The constraints, of course, is that you need a strong population-based death reporting to capture something like excess deaths. And so now I'm going to shift a bit to talk about more generally how we think about social disparities in the US context. So race has been at the center of COVID-19 disparities from the very beginning. We see here in both of these plots that race ethnic minority groups, Blacks, Hispanics, and Native Americans had higher cases, but especially higher deaths per capita from the very first wave. It is not just about Black Americans, and it is not just about death. We see that there are higher than, in terms of cases, hospitalizations, and deaths, virtually all ethnic and race minority groups, except for Asians, have higher rates compared with white Americans. And what we see, if we look at the data a little bit more closely and contextually, is that this is because we're really failing the public at the margins. On the left-hand side, I'm showing a county level plot of poverty distribution. So this is county level poverty, and I've highlighted the top quintile of poverty. On the right-hand side, I've shown case rates and death rates by county level poverty. And we see that it's in the very highest quintile of poverty that we see the highest COVID-19 deaths per capita. And you see that kind of a gradient also with the cases, but you see that the gradient is steeper with the deaths. So this is all the motivation for us to track health equity using a contextual perspective through our health equity dashboard. You can see that county level disadvantage is geographically concentrated. And again, I suspect, or not I suspect, I know from working in India that we might find similar patterns in in India using other social metrics. So I am, in the interest of time, I'm going to just try to skip over a couple of these slides and get straight to the COVID-19 health equity dashboard that we have created based on this, contextual picture that emerged very early on. The goal of the COVID-19 health equity dashboard was to consolidate and synthesize localized data on COVID-19 outcomes and context. We wanted to bring attention to health equity and COVID-19 outcomes and bring a narrative to that story. And especially when we first started this about a year ago, there weren't as many efforts at the central level or among private organizations to really look at the socio-contextual determinants of these patterns. And our approach is an ecological one. So we take county level case rates and county level death rates, and then derive various graphics as what you see on the right-hand side, scatter plots of social vulnerability on the x-axis, and death rates on the y-axis is one example. On the bottom right, you see a bar chart of quintile of poverty and death rates, which I've already shown you. And essentially, you can go to this website and interactively benchmark how a county is performing against the state and the nation, and also examine how social determinants in a county relate to those same social determinants in the state and the nation. So we have these detailed measures at a county level. You can get for the data nerds, get more these scatter plots and those sorts of metrics. We also have added a vaccine tracker at a national level and a state level, because the pandemic is extremely dynamic, and we attempt to be responsive to what we're seeing and capturing aspects of the response. And we also have measures. We have recently introduced a Georgia level dashboard that uses that State Department of Public Health data that I described earlier. And that was at their initial request, that they were interested in seeing how we could get more granular for the state of Georgia with some of these data. And I'll say, though, since we started this work, the Health and Human Services in the United States and the CDC have also really begun providing data in a more usable fashion, accessible fashion. And so I'm just sharing with you the community profile report that is put out on a daily basis. So some glimpses of what that looks like. All of that, from the provider to county to state to national aggregated data is what you're seeing here. So you see heat maps of cases and also percent change by counties. You can find the area of concern continuum described and reported. You can also find on the CDC website very detailed pandemic vulnerability reports. So these are some of the tools and some of the limitations that we're working with in the United States. I'm going to stop my comments here, but I just want to acknowledge that there's been an incredible team of students and faculty that have come together around this work. Many of us have never met one another. It has all been done remotely, and I must thank them for their contributions to the work I presented today. Thank you.
Thank you. Thank you so much. That was very, very insightful. And I think it was a great learning for all of us. And thank you for taking us through the details of the methodology of data collection. And you very nicely pointed out all the limitations, because limitations always help improve the understanding of the issue. So that was very, very, very interesting. And also, I think what I really, I like the use of the term testing hesitancy, the bringing in of psychological behavior into the testing. It is so real. We see it, but I hadn't heard of that term, testing hesitancy, which is so very much there in our society and in many others as well. Thank you so much. We now move on to our next speaker. May I invite Dr. Anand Krishnan to share his views on COVID-19 surveillance in India. And Dr. Krishnan, of course, has been part of the AIIMS faculty since 1994. He is currently a professor at the Center for Community Medicine in AIIMS at New Delhi. He has several publications to his name. He heads the WHO Collaborating Center for Capacity Development and Research in Community-Based NCD Prevention and Control. He has worked as an international consultant for drafting of the National NCD Prevention and Control Strategy for Myanmar, Timor-Leste, and India. He has also provided technical assistance to health ministries of several other countries, for instance, in Bhutan, Nepal, Maldives, East Timor, and Sri Lanka. He has also led the WHO team for drafting National Health Research Policy for Bhutan and Maldives. And he's also a member of the WHO Working Group on Global Influenza Burden Estimation. Over to you, Professor Krishnan, with your vast international experience. I'm sure we have a lot to learn, and we look forward to hearing the international experiences from you.
Thank you. And I'm going to just share my slides. Can you see them?
Yes.
Okay. Thank you, Nisha, for that introduction. I'm going to be maybe, I think, following Shivani, I'm going to be a bit, we can call, start at least textbookish and then move towards maybe more important issues. Anybody who knows public health surveillance is familiar with this diagram which I'm showing on the right. There are 4 things in any surveillance system, which are the events of interest. What is this data collection or reporting system, which generates the information, how we analyze and interpret it, and how we link to action. The key point here is always action. All surveillance is geared toward action. So any information we collect has to have a clear link with action. Otherwise, it becomes a research and not necessarily an action, surveillance. So let us take each of these 4 and see in terms of COVID, what is of interest. And I will apply Indian lens whenever it is necessary. So you can see that I'm sure by even just by reading newspaper and by we are monitoring a lot of things which, parallelly during the current pandemic. Obviously, the most important is the epidemiological parameters of the disease, which monitors the progress of the epidemic, both in terms of time as well as in terms of geography, by state, by district, by cities, and by, in fact, day to day. The primary reason why we monitor many of these surveillance and this is that we want to predict what is going to happen. And prediction by an alert and maybe by a modeling, obviously modeling depend a lot on the surveillance data, is what is an important outcome of surveillance, that we are able to predict what is going to happen next and therefore do something to prevent it. That's the key reason why we do surveillance. And as Shivani just pointed out, we also like to identify risk groups so that we can focus on them when we are intervening, whether it is by socioeconomic status, race, ethnicity, caste. And as I said, all of them are related to public health. We want to roll out public health prevention. A lot of these issues in the COVID context is on restriction measures, lockdowns, and when can we impose them, when can we remove them. These all should be based on data which are available. And we would need data to make such kind of decisions. And in kind of a surveillance of an infectious diseases like COVID, we would like to also know individual cases because we want to do contact tracing. It is not just numbers, but also individuals so that we can do contact tracing, find people who have been possibly infected, isolate them or quarantine them as needed so that we prevent the spread of this infection. So, and finally is the health system preparedness, both in terms of preparedness, and we know that what is happening in India, Delhi and many parts of India shows sort of lack of preparedness in terms of resource availability and their utilization, and health outcomes in terms of case fatality rate, ICU rates, and those kind of things. We want to know how well we are doing. They tell us about that. And finally, very pertinent to this COVID pandemic, is on the socioeconomic dimensions of the pandemic. What is its been socioeconomic impact in jobs, in incomes, and also use it to measure inequities in the disease and its impact, again pointed out by Shivani. So these are various parameters or domains on which we want to do surveillance. And therefore our events of interest are also vast. There is a whole list of things which we want to measure if we want to monitor this pandemic, right from disease burden parameters, incidence, and mortality, and we discussed about deaths. Shivani discussed about deaths and its counting. The case definitions, again, we have, I think Shivani spoke very well about the case definitions, their sensitivity, specificities. Each surveillance has to, in the given context, if you go for a lab-based, it will have its own limitations. If you go by a syndromic approach, it will have its own limitations. And having disaggregated, aggregated data by age, sex as the least, but definitely by other risk groups and vulnerable groups. Another thing which we want to know is compliance to different interventions that we are seeing. How many people are masking or not masking? How many people are maintaining social distance? These different directives or guidelines by the government, how much is compliance to them? What is the risk perception of the people? These are important, especially if you have to deal with communication campaigns, which are an inherent part of public health preventions. And once we roll out vaccination, we know we need to look at adverse event following immunization surveillance. We want to track basic vaccine hesitancy. We also want to track real life vaccine effectiveness by doing post-marketing surveillance after they have been, the permissions have been given post phase 3. And environmental information, and we heard the One Health aspect, and it was good to hear from Roli that there is going to be a National Institute of One Health in Nagpur. And we have learned in this that that's an important interface that we need to do a complete surveillance on. Also sewerage surveillance, we know that, especially we learned it from polio, that a lot of these viruses can be tracked in sewerage systems. So again, that's another channel of information. The health system parameters and the socioeconomic parameters. So again, we have a vast range of things which we want to monitor. And obviously they will result in vast sources of information. You have different sources of information. For health, there are population-based platforms, there are hospital-based platforms, there are laboratory-based platforms. Mortality surveillance platforms are entirely different from many of these things. There are disease notifications which occur during pandemics, which are often practitioner-based or lab-based and not necessarily hospital-based. We have a One Health surveillance, which looks at surveillance in animals. If we have a good routine surveillance, many of these things are taken care of. Like we have the integrated disease surveillance program in India, routine health management information systems. Many countries have SARI surveillance platforms, which is for severe acute respiratory infections, which are also used for influenza surveillance and can also be used for COVID surveillance. So if you have a good existing surveillance platform, you can quickly build additional platforms over that. For COVID, for example, we need rapid surveys. We might need communication related risk perception surveys. One thing which has come up big in this is the whole use of big data and the use of ICT for this thing. We saw even from the maps that Shivani showed, and even we know from the Indian, this time we have a lot of data aggregators where they have aggregated data and presenting it in a form that people and different stakeholders can understand. That makes the use of data much more easy for all the stakeholders. And obviously in a disease like COVID, the geographical positional system of cases is an important parameter to measure. But in the Indian context, the elephant in the room is the data from the private sector. Largely our surveillance systems do not catch what is happening in the private sector, both in terms of health system preparedness, in terms of disease notifications or a number of cases or deaths. And without that, and considering the fact that a good chunk of our outpatient and inpatient healthcare utilization occurs in private sector, that is always going to be our Achilles heel. And we need to create a mechanism by which this information is routinely poured into our surveillance system. And we need to look at, but even though individual surveillance systems need to be simple for people who want to report them, it should be very simple reporting systems, but at the same time sensitive, and timely and sustainable. We need to look at systems which are sustainable, because even for COVID, it is not going to finish now. It is going to be there for years, and we need to start thinking of more sustainable, move from ad hoc systems to more sustainable systems. So in the last, obviously, once you have systems in place, and you know what data to collect, you collect a lot of data. The problem is with how do we work with those kind of data? How do we have people who put all these data together, make sense of it in a timely fashion? Because as you can see, there are a lot of things, moving pieces here and there. We need to have a good team or a capacity or an institution which puts all these jigsaw puzzle together and comes up with the final image and provides advice to the decision makers. Here also, most of the surveillance systems actually generate numerators, and without a good denominators, it is not easy to interpret these numbers. For example, number of deaths is a numerator, but if you want to put it as a number of deaths per 1,000 cases or 1,000 infections or 1,000 population, you need denominators. Often in the Indian context, we are not sure of our denominators, and therefore comparisons becomes very difficult. Just comparing numerators is not a good way of comparisons. We saw an extensive use of real-time dashboard, which also Shivani talked about. If we have so many systems, we need to look at how we have interoperability of the systems, and that's, I think, some area that we still need to work on. Shivani referred to who is the person who is going to take action. It is at district level, is it at state level, is it at country level? Where should this capacity be built? Who will decide on schools closures, workplace closures, market closures, and those kind of things? And we need to build capacity at district levels, at the health system preparedness. Definitely, we need to look at how we can use these surveillance measures for communication and messaging, and we can address at-risk and vulnerable groups. In the end, I would like to again touch upon the point that Shivani made. There has to be a trustworthiness of the data for action. If the trustworthiness of data is not there, then the actions are going to be not useful. You just cannot have any data and take action on it. So that quantum of trust is very important. The capacity to act is very important. Channels for communication of these data to decision makers. Remember, these are complex sets of data. How do you communicate these complex sets of data to decision makers in a meaningful way that they can decision? And finally, I think it is time that we also look at communities as equal partners in decision making and create systems by which this information is also transferred to community. They should be an equal partners in many of these surveillance. That thought process has to start entering our thinking. With that, I end. Thank you for giving me this opportunity.
Thank you so much, Professor Anand, for laying out the framework. It was very, very lucid, and I think what the real challenge is that we are still going through the pandemic, and the parameters that we want to monitor are still evolving. So with newer strains and newer things happening every day all around the globe, and differences across countries. So I think this is a huge challenge for all of us. But thank you so much for laying down the framework for us so lucidly. With that, we come to the end of the session, and I am just checking if there are any questions. Well, there is a question which says, "Dear all, the current mutant virus, is it airborne, as so many people are getting infected?" Who would like to answer this? Professor Anand, would you like to answer that?
Sure. I don't think this the airborne is a mutant issue. I think there has been debate going on whether it is an aerosol or an airborne. There have been some publications recently which have made a case that this is an airborne. Yes, if it is an airborne, the spread is going to be much wider. And as I said, it's not necessarily because of a mutant strain that this is happening. It is already there.
Right, right. Well, I've also gotten a lot of comments, more than questions, and the comments are actually saying that the discussion is excellent, and they're thanking all the speakers for their presentations. And I think there are several such messages that have come in. So I'm very happy to convey these messages to all the speakers. 1 minute. I think there is some other question that is coming in. Okay, there is another question which says the need for one health platform. Your comments, please.
I think comment is very simple. It is absolutely necessary that we should have a one health surveillance platform.
Okay. Dr. Mathur, would you like to comment on it?
Absolutely, as to what Dr. Anand just said, it's so important, and that is why I did mention about the institute that is being planned. Of course, it will take time for it to be set up, but then that is what is the aim. We have to handle everything in an integrated fashion rather than in bits and pieces. So that is the ultimate objective of achieving One Health.
Shivani, would you like to add to that?
No comments on this one. I mean, I just support what's been said already.
Okay, thank you. There is another, yes.
Rimmele would say something.
Yes, yes.
Maybe
yes.
not a question, but maybe a comment. Yes, I agree with it. Of course, there's no question that you should have this health platform. If I look at Shivani's finding, maybe to simplify it a little bit, that the poorest have the highest death rate should not be a surprise for anyone. Specifically not in the US or anywhere. For me, that is a result also, if I compare to other countries, and if we look into recommendation, we might have to do that, where you have in general a healthier situation of the population, because there is some at least basic health care, the risk of dying is at least lower, and that would be, if you compare other countries, probably one of the findings. The basic health status of a poor population, if there is no healthcare system, like in the US, is they will be quickly hit by anything else, and also by a pandemic. Even if you compare, let me say, several European countries, you will see much higher death rates in others than in the compared ones, because their basic health system is not functioning that way. And this is one, we have so many, let's call it preventive examinations for cancer, for whatever, what are all normally paid by health insurances. You find other things too, if you do them. And that is what increases the general health level of a country where there is a functioning healthcare system. What I would not count the US to it. Again, if we have recommendations, Shivani said there should be more population-based reporting. Now that is a matter of a system of a country. We have different countries. I would say still a better population-based reporting may increase the accuracy of data, but it's still weak. It is much better, I would say, to have government-based reporting systems like a civil registry or like a residence reporting system, whatever. Then you have much more accurate data. But that is a matter of administrative, let me say, tradition. It would be difficult to impose something in the US. In other countries, it's normality. So if we look into lessons learned, we may also have to differ and distinguish between different administrative cultures of countries. Thank you.
Thank you, Mr. Rimmele.
If I could just respond quickly, I absolutely agree, Mr. Rimmele. And I think actually by saying population-based, what I meant to some extent was contrasting it from clinic-based, and that was probably not the right language. But I was thinking to this, to some extent, this problem of the numerator that is sporadically captured and only among those who are the sickest and die and come to the clinic. So I think your call for civil registration systems, residence reporting systems, all of that is absolutely warranted, and I appreciate that.
I have a question, if I may ask. of the panelists?
Yes, please.
It is very clear that we need a global response to similar pandemics that may happen in the future. What would your recommendation be for something like that, apart from the fact that WHO exists, WHO exists? However, what additional teeth does it need? What else should governments have done or should be doing in the future to have a global response? Because this virus doesn't know any borders and doesn't know any boundaries or electorates. And while a WHO is there, in the absence of sufficient teeth, how could we make a global platform and a global response far more effective? I'd love to get people's views on this. I hope I'm allowed to ask the question.
Yes, of course.
And I hope we are allowed not to answer the question.
Well done, Anand.
I was going to wish for the possibility to just nominate Dr. Krishnan and Dr. Mathur to take those questions. That was my.
Well, I think your question is very valid. We all know that in this time, we would all like to have an international organization, preferably WHO, to have teeth in many of these matters. But I think these matters for much more international diplomats to look at rather than people like me to talk about. But the need for such an agency and need for a global relook at the role of WHO in these kind of situations is definitely there. But I don't see any easy answers for that. I think there is going to be a lot of diplomatic tussle which is going to take place on this issue. May not necessarily end up in a product or in a situation that we would be happy about. I think this is going to last for at least for some period in future.
That's quite depressing.
Anyone else?
Yes, there is one other question.
No, I meant as a response to this question.
Oh, I see. Okay.
No?
Well, I think you have raised such an important point, and I think that is what we all look forward to. And I think the word has risen above, what it was last year. There has been, to look at it from the positive side, there have been enormously, global efforts, and there has been a lot of collaboration that we have never seen before. We are moving towards that direction. I don't say that everything is sorted out. We are far, far away from what is we need. But I do see that we are moving in the right direction, and the way we have responded, the whole globe has responded, how people have been brought together. I think we have examples of multiple collaborations that have happened, multiple platforms where countries have contributed to the WHO guidance documents, and there has been enough engagement with a number of stakeholders. Efforts are being made in that direction, and we have evolved, we are evolving, and we are getting better. That would be the positive note. Thank you.
Perhaps that's an area ICRIER can certainly look at for the future, perhaps collaboratively with many of you, to really try and address that burning question of how can we make a combined global response more effective. Sorry, Nisha, I'll turn it back to you.
No, thank you. There is another question from the audience. Why, in spite of socio-economic surveillance data collection, we couldn't predict the second and the third wave?
Okay, if I have to answer that, I don't think the data for prediction is more of an epidemiological rather than on social and economic data. See, the problem is that most of us predicted the second wave, but none of us predicted the severity of the second wave. I think where all of us failed. It's not, I think the entire public health fraternity failed. None of us expected this wave to be as severe as it turned out to be. I think a lot of things will be written about why we had this severity. I don't think we have the answers as of now. We'll have to wait and see what happens and how we, hopefully we'll have some answers at somewhere in future. Why did we miss this? But I don't think we have answers at this stage.
True. We also don't know how long this is going to last.
That might make it easier to predict, because once the wave starts, then it is easy to predict when it will end.
Just follow the normal curve prediction?
many of the states have started stabilizing. So in India, the problem is that different states will be at different stages of pandemic. So we'll have this go over a period of time, but individual states or cities will come down quickly. Then next one will start and something like that. So that is going to take place for the next 3-4 months.
So I have a question for Dr. Krishna and others. That yes, the severity was not predicted, but at the same time, what we know about interpersonal transmission, congregate settings, could we not have foreseen that some of these consequences, that a second wave, would arise based on human behavior? So I appreciate what you said about the socioeconomic surveillance can't really tell us about that. That's in many ways pretty static, right? Sort of the socioeconomic distribution of the population. It's human behavior that's dynamic. So could we not have had some idea that that a second wave was coming?
Again, we are not really monitoring the behavior, as I said, and I said that that's something that we should be doing. And it's very important for us to do that, so as to launch a communication campaign which captures this kind of a thing. But yes, anecdotally, many of us did see the lowering down of our guards, people walking without masks, and lots of crowding occurring. Even in parks, I would walk and there would be a lot of crowd. So yes, we were making the grounds for the next wave. We were preparing ourselves for the next wave in that sense, yes.
Would it be fair to say that in the second wave, the voluntary restraint has been higher than in the first wave?
Restraint to do what?
Voluntary restraint in the sense of compliance?
To the masking and all?
Yes.
So it was less, but now with this kind of panic, it will swing to the other end. Then again, it will gradually come down. So that's the way it will go up and down, depending upon the public perception of the risk. The compliance to the interventions will keep changing up and down.
It's the fear factor which will do that to us.
Yeah.
But I think to your question, Shivani, certainly all the offices open, government offices were always open, elections were continuing, all of those events were happening with a clear thought that the worst was behind us. And I think despite the data,
right,
we continued that kind of behavior. But the severity, I don't know that anybody predicted as.
Don't get me wrong, I was not predicting this.
No, I know that.
See, I also, I mean, it's anecdotally and otherwise, because I have not been working on tracking India's epidemic, just reading, as others do in the papers, thinking, yeah, what happened in India? I mean, I think that we were all wondering, wow, okay, India just seemed to beat this. I was also one of those people, but it's also in hindsight looking at the human behavior dynamics that it seems.
Incidentally, we also did not, we expected the first wave to be much bigger than what it was.
Exactly.
So in both the cases, we got it wrong. In the first one, we thought it would be bigger, it was much smaller. Again, we don't know exactly the reason why it happened like that. Second wave, we thought would be smaller, has become much bigger. Again, we don't know what. So I think there's a lot of unknown things here, which we need to know, understand better and study better.
False victory and false hope, unfortunately.
Just to say, surveillance just tells you what is happening. How to prediction is still a different ball game. Surveillance is just a set of tools which helps you predict, but surveillance is by itself not good enough to predict.
Okay.
So with that, I think we come to the end of the session. It's been a very, very engaging session and a great learning for all of us. The times are bad, really bad. The mood is somber, and it's all right to pick just half a line from Dickens, which is, "This is the worst of times." I won't add the rest of it, which is the best of times, but it certainly seems to be the worst of times. And let's hope that all experts who are working in this area, they're doing They're really doing their best, and it's going to be a great contribution from all of you here to maybe one of the worst disasters, human disasters that we're going through right now. With that, I think let's keep up the good work, and we will continue to engage on this subject. May I thank CAS once again, Mr. Rimmele, for partnering with us and giving us this opportunity to work on such an important subject. We hope that we can continue to have the remaining seminars on this subject, and we continue to engage on this very, very important subject. Thank you once again, all of you. And with that, we come to the close of the session. Thank you.
Thank
Thank you
you.
very much.
Thank you.
Thank you.
Bye-bye. Thank you. very
Best
much.
wishes to all of you in India.
Bye-bye.
you.
Thank you.
Bye-bye.